I just had a comment on the last presenter about peripartum pyrexia. 10% is still a number needed to treat, high enough for me to say I'd rather treat. We are treating people with antithrombolytic drugs at much lower evidence for benefit, with a much higher risk therapy. If you came to ED with a chance for MI, you give aspirin to every patient with chest pain, and you might, with a risk for 10% for aortic dissection and 3% for GI bleeding. I know that the cataclysmic antimicrobial resistance movement. I work closely with them. I do a lot of research on that side as well. But on the clinical flow, unless you're a really senior doctor seeing the patient, I would be very uncomfortable to say, let's just wait and watch. If the next watch is going to be after 6 hours of clinical rounds in every other department in the hospital. Mm-hmm. So I really think when people present odds ratios and say, oh, well, we still had 10% of patients who had confirmed BSI, so 4 out of 22 to have confirmed blood culture, that's still significantly higher than the ED sepsis population of positive blood cultures.
I think that's it. David, would you like to, there's a mic there beside you.
We're still saying to actually treat these patients, while it's a 10% rate of infection, we're saying that this could possibly be due to the epidural or the effects of labour. We're not saying to not treat the patients, we're saying to give them more time to cool off and be kind of a bit slower to start them up with a septic workup. It's definitely not saying to not treat them, yeah.
Yeah. Well, thank you very much.
Yeah, I think that there's, I suppose, there are two messages coming through. One is the management of pyrexia in labour, which is not sepsis. It's pyrexia in labour. Some of them may be sepsis and some may not. And then there's the issue of the infections. I suppose, just to reiterate what Dr. Shetty was saying, that most sepsis literature would say that blood cultures are only positive in 40% of cases where there's severe sepsis, and rising up to 52% in septic shock. So it increases the more severely ill the patient is. And in the intensive care population, when you do a full septic workup, so wound swabs, sputums, urines, as well as blood cultures, in patients with septic shock, you may get a positivity, a culture, identify a microorganism about 80% of the time. So we know that while our microbiology colleagues do great work, the techniques that we have available to us currently don't give us 100% of the time identify the organism. So 17 and 10% infection rate based on organism identification likely underrepresents the actual infection rate.
But I suppose, in fairness, you weren't saying not to treat.
Oh gosh, no. No. The recommendations are excellent, and it's a very interesting study. Thank you very much.
Start it, but it's hard to get the people to stop the antibiotics.
Yes.
But that's what we need to do. We need to, they say, start smart, then focus down after 48 hours. It's a simple enough message, really.
Yeah, and we fully support that.
We've a lady behind. I'm sorry, I don't know anybody's name, and then yourself, Mary.
My name is Mary Houlihan. I work in the Rotunda Hospital, and we did something a little dissimilar, but it was again looking at issues in relation to identification of patients by the new documentation. So we took a group of patients who had delivered, so it was a retrospective study, and we looked at these patients and found that a very, very significant proportion would have triggered sepsis 6 based on temperature, which I'm glad to hear is validated. But the other issue was heart rate, blood pressure, all of those which are significantly changed in pregnancy. So we need to look at what our norms are in relation to the pregnant population. And this led then to a significant increase in that group of patients if we had been using the documentation to instituting antibiotics. These were patients who had delivered and hadn't shown any signs of infection through their pregnancy, labour, delivery. And it also significantly increased the workload and therefore expense, or potential expense. So it is a problem when we look at the pregnant population. You know, even some of the American work will show that you trigger a lot more intervention. So I just think it's an area that we just need to be a little cautious about in relation to the physiology of pregnancy.
Thank you. Can I just bring a little bit of clarification? The national programme and none of its documentation recommends the initiation of Sepsis 6 based on SIRS criteria. The SIRS criteria helps describe a host response to an infection that will describe sepsis. So it's not the SIRS criteria per se that trigger the treatment. The SIRS criteria in combination with infection acts as one trigger for the Sepsis 6. So just to make that clarification, and in fact the Irish programme has been quite different from American and UK programmes on that, in that we don't use SIRS as the screening tool. Our starting point is always the clinical suspicion of infection as the cause of the patient's deterioration, and then we assess the host response.
We've a question here.
My name is Dr. Steiner. I work in the Galway Clinic. We've discussed this, Vida, as well, that one of, in my opinion, a good parameter for stepping down would be procalcitonin. I think not as a trigger to treat, but as a trigger to stop. What do you think about that? Will that be considered as part of an algorithm, or?
Yeah, I think that's something that there's a lot more work being done at the moment, and Dr. Shetty is in fact involved in a study, and they're going to shortly publish on that. Procalcitonin hasn't been demonstrated yet to be a useful marker to distinguish whether a patient has sepsis or not, but it has been shown to be very helpful to add to the clinical picture in helping you stop antimicrobial therapy. So I think that will be a really helpful biomarker.
We had two questions towards the end. There was there somebody on this side? No. And then there's a lady here.
Hi, Bernadette Murphy, antimicrobial pharmacist from UL. Not to hog the obstetric side of things, but just one more comment about the pyrexia in labour. I suppose it's just to remember that there's also the neonate. So I suppose it's a unique scenario where what you do with the mum has an implication for the neonate. And I know in the BMJ recently there was just the questions raised. Again, it wasn't drawing any conclusions, but it was just about our exposure in neonates to antimicrobials because of our seemingly, anyway, increase in antimicrobials in the mum.
Yes, and I think that there has been a big increase, a sort of a gut reaction and an increase in use of antimicrobials. And we hope in the national sepsis programme they'll be able to modulate that and bring a more rational approach to antimicrobial prescription in maternity, which is why we're piloting rather than rushing in with a national screening form.